Okay. So okay, I didn't get the question because my thing was echoing. So
Madam, how did we calculate that fluid rate, and was he polyuric that time? Because 670 ml was
no,
urine.
he was not. He was not polyuric. He was having a. He was a 70 kg kid. He was an
Okay.
adolescent with like an adult body weight and height. So what we did was we used the adult decay protocol, and you chose the one which had the lowest fluid requirement
Okay.
because he was not a true decay. He had hyperglycemia. So, that equivalent to that 3%, 5% decay, that level we chose from the adult thing. So we didn't do a body weight calculation for him.
Okay. Okay.
Because many times when we do that for children above 40, 50 kilos, we end up giving higher than the maximum adult values.
Okay.
So it's better to go on the small adult recommendations which they give for 50 kilos and all that, and choose according to that for fluids.
Okay. Thank you.
Coagulopathy in like high doses, ma'am. Like in this case, like was that also ruled out? Like whether
Yeah,
it's causing
levels were not high, and the biopsy has been done. Actually, it's had 3 biopsies. There's no TAC toxicity, CNI toxicity. So this is not CNI, and there was proper single antigen bead assay, high titers against donor, and then biopsy compatible with antibody-mediated rejection, C4D, etc. Then even now he had a TAC level done. Yeah.
Okay, thank you, ma'am.
Yeah. If any more questions on the first case, otherwise we'll go to the second. Jyoti, shall we move on?
Sure, ma'am. Yes, ma'am.
Yeah. So this is a 10-year-old boy. His primary disease was an Alport syndrome. He developed, he presented with nephrotic syndrome at 2.5 years. So it was a little unusual for an Alport, but a very strong family history and subsequently proved by genetics also. He underwent live donor renal transplantation in November 21 with father as the donor. Good graft function. He was non-hypertensive. Pre-transplant, when he was uremic, he had a single seizure and so was on Levera. Now, 3 months post-transplant, since that was one single seizure long ago, we had stopped the Levera, and he was now only on TAC, MMF, and prednisolone. Now he's been on regular follow-up with no major issues. And he came with a history that he had a mild headache from the previous evening and was not feeling too good. And at night, he developed high-grade fever, 102 degrees, which was continuous, wouldn't come down with paracetamol, tepid sponging, etc. But he was passing urine, and because of post-transplant, usually we keep on harping about taking water. They usually take about 2.5 liters, 3 liters water. So at night during the fever also, parents kept giving him water. At night, they woke him up, gave him some tea, etc. But he didn't want to have breakfast. He had a generalized tonic-clonic seizure in the morning, which lasted about 10 minutes. And he needed 4 puffs of Midas spray, which they had at home. They took him to the ER at Jupiter Hospital, which was next door to them, and he was loaded with IV Levera. After the convulsions were under control, they kind of came to Lilavati because that's where he got his transplant and care. And clinically, his vitals were good, mildly hypertensive for his baseline, what he used to have. SpO2 was normal, peripheries were good, CRT less than 3 seconds. CNS-wise, he was drowsy. You had to kind of wake him up, shake him up, wake him up, painful stimuli would get up, or repeated questioning, he would open his eyes. He would not talk, but he seemed to understand, like in terms of a little nod or kind of thing. But otherwise, no deficits, reflexes, everything was normal. So any thoughts with this? A post-transplant patient, 9 months post-transplant on immunosuppression, coming with fever, headache, seizures. Yeah. So anything? So anyway, my first thoughts were that whether he's developed some viral meningoencephalitis, because immunosuppressed person suddenly with fever, headache, seizures, or did he just have some fever and because we had stopped Levera, now he has no anticonvulsant and he is seizure prone, so it's thrown a seizure. These were the two thoughts in the mind when he came. And this was his first casualty, which they did is blood gas. And again, he had a mild metabolic acidosis with an normal anion gap. And his sodium showed 123. His glucose was normal and the rest of it was okay, little mild low potassium, but otherwise okay. History-wise, there was no loose motions, no vomiting, no cough. This was all the history there was there. So nothing really to account for any sodium losses that could be there. So then the question came that could he be viral encephalitis or meningitis with SIADH? So this obviously question of pseudo-hyponatremia doesn't arise because there's no background of high lipids, high proteins in the body or given any other medication like mannitol, etc. for translocational. Glucose was normal. So probably with this, it was considered that it was a true hyponatremia, and almost also with direct potentiometry, the sodium was 123. Again, in this child, we did not send osmolality. Maybe we should have sent. But his other investigation showed a BUN of 15, creatinine 1.19, which was a little higher. He had for the last couple of last month a little higher creatinine than his baseline, and this is little higher than that. CRP was practically normal. Procalcitonin was negative. The serum from the chemistry lab was 125 with little low potassium, bicarb 19, little polypredominance, otherwise nothing remarkable. From the time he came to the hospital, there was no fever at all recorded, right from casualty. The osmolality calculated was 262. Now, calculated osmolality is more to give you an idea of how low the osmolality may be, which is of course made out by your sodium itself. You should use it only if you're sure it is not a pseudo-hyponatremia. Only then you can use that. So then comes now your approach to managing this child now. Is he asymptomatic or symptomatic? Obviously symptomatic. He has a true hyponatremia. He's symptomatic and the symptoms are severe because he's had seizures and he's had altered sensorium. Of course, we don't know to what extent the altered sensorium was little post-ictal, but still severe seizures lasting for 2 hours, 10 minutes, and then altered sensorium with hyponatremia will be a severe hyponatremia. Now, cause of the symptoms, we all know why does hyponatremia cause symptoms? That when your sodium goes low from your blood, what happens is your intracellular compartments now has more particles. So it will draw in the water and your intracellular compartment will enlarge. And in the CNS, this is what happens, that water moves into the cells, the brain swells, and there is increasing intracranial pressure. So these have to, when you have low serum sodium, very often at that point of time, you do not know what is causing it, why is it caused, etc. But the only thing you need to know is this: are they symptomatic with the sodium? If they are symptomatic, no matter what else may be there, that sodium needs correction, because what will happen here is that there is already cerebral edema, and it doesn't take very long for coning and death to act, respiratory arrest, death, etc. to follow. As opposed to that, in the first patient who had even lower sodium, he had 117, this one has 123. We did not give 3% sodium chloride because he was asymptomatic. That means he does not have cerebral edema. His brain has already adapted by throwing out this extra osmoles. So whatever osmoles it has, if you give the brain a little time in order to bring its volume back to normal, it will start throwing out these osmoles. Or if your sodium hyponatremia has developed more insidiously, it has time to throw out the sodium. So now its sodium, its osmolytes are not so much more than the vascular compartment. So it may slightly increase and it will eventually equilibrate. So since the osmolality is now balanced, if you now give 3% NaCl in a balanced state, you will cause more problems. So that is why in that child, we did not give 3% NaCl. So the only thing that is the differentiating point is symptomatic or asymptomatic, which tells you to give 3% or not give 3%. Now, in addition to this, now till night he was passing urine. But ever since he had the seizure, and he was one not taking obviously orally, then at Jupiter Hospital, they gave Leveran because the parents want to come to Leelavati. They hadn't started IV fluids. They had only checked HGT. And by the time all this happened, he came to from Thane to Leelavati, and then casualty, and then COVID testing, etc. He had not received fluid. Clinically, he was looking well dehydrated. So by that time, it was almost 5 hours that he had not received any fluids. And that becomes a little tricky when it's a post-transplant patient, because normally he takes about 100 ml fluid roughly per hour. So I calculated that he would probably be down by 500 ml. So I started 500 ml NS over 1 hour to kind of restore his volume and that he may pass urine. The question, and I also gave 3% NaCl, 5 ml per kg over 1 hour. We had sent a pediatric neuro reference because we were not sure what we were dealing with. By the time the pediatric neurologist came to see him, his sensorium after that 1 hour had improved. He was sitting up, he was chatting, he was feeling hungry, he wanted to eat. So the neurologist said that even MRI we can wait, this seemed to be just sodium related. So let us wait and see. And he passed 650 ml of urine. VBG done after this 3% NaCl was over showed a sodium of 133. Now here I need your comments. So what would you say? Is this treatment given okay? Is the outcome okay? Are you happy with what has happened? Should we have done something differently?
Ma'am, did we check the urine sodium at some point?
See, what happened was this kid, when he didn't pass urine, we debated about catheterizing. Because I thought if we had a sample of urine, we'll send for urine osmolality and electrolytes. But because of his immunosuppressed state, we were not too keen to catheterize unless he remained altered. Let us know. This 650 this urine didn't go for any testing after all this game. Before that, he had not passed urine. He may have had some urine in the bladder if he had catheterized, but we didn't catheterize. So these are things where many things which ideally we should have done, we have not done. We didn't do a serum osmolality. We should have catheterized, taken a sample, sent for osmolality and urine electrolytes, before we gave all this, which we didn't do. So this, anybody, any other comments?
With an acute event, we could risk correcting the sodium so quickly. Otherwise, that would be another consideration.
Sodium so quickly in the sense?
If I remember correctly, the sodium level was some 119 and it was corrected over 1 hour.
Yeah, it was 123 and now we have 133. So I agree totally with this point that we have overcorrected. So
maybe that's why there's no harm done. If it was a chronic hyponatremia, that would be really harmful. Maybe in an acute situation, it would not bear much of a consequence because there hasn't been time to found those idiogenic osmolytes which are known to cause the problem.
Yeah, so I agree. Why did the overcorrection occur? See, ideally, even if it does not cause harm, which is again a moot point for discussion, which we'll come to, obviously clinically is looking good, but we've jumped the sodium. What should have been in 24 hours, we've corrected in 1 hour. You would expect that you'll correct 10 milliequivalents over 24 hours, and you've collected 10 milliequivalents over 1 hour. So that is little alarming. So how much do you expect 3% NaCl will increase if we give 5 ml per kg? How much will the serum sodium go up by? So normal expectation is that it will increase it somewhere between 3.5 milliequivalents more. And that is probably to reverse the cerebral edema and prevent any immediate catastrophe. So that was the expectation that we said from 123, it will probably go to 126, 127 at the most, which is sufficient for that point. And remaining we can correct over 24 hours. Okay. So what do you think else could have gone wrong here or gone differently? Okay. Now, one thought, there were two things here which have happened, which I put here. One is I gave 500 ml NS over 1 hour. There were two different reasons for both of those fluids. And the child also passed 650 ml urine. So now let us see all this, how it works. Why did we overshoot? Yeah. So the worry we are, what we are worried about, when we are correct rapidly is that the child may develop an osmotic demyelination syndrome, which occurs because of rapid correction of sodium. You cause astrocyte damage. And all this cellular damage, various things may occur before you can detect demyelination even by MRI. Okay? So the child may not immediately have a neurological problem. It could develop days or even weeks later. So that is another fear that because the child looks okay now, we may not be very sure we have got away with it. The history sounds as if it's a short history. But it's a dramatic fall. This child who used to have serum sodium measured periodically when his follow-up of 140 has come at 123 serum sodium. whether it all occurred in that one night, or was it falling and it worsened at night, we don't know. So in case it was going more slowly, then we may not be as safe as we think we are. So what really happens is that the brain has now adapted because it's a slow development. And so it has already thrown out some of its osmolytes, which I said. 3% NaCl and increase osmolality, it will draw out water from the cells, and the brain, while trying to maintain its osmotic particles, will start breaking down proteins to provide those osmotic particles. So you get structural breakdown of your proteins in the CNS, and that's what causes the demyelination. Okay. Now I'm going to go to something which may not be the best kind of exercise for medical brains, but it was worrying me that how did I overshoot so much? What did I make a mistake in? So I calculated. Now, if you use many of you may be using the Adrog-Madias formula for sodium corrections. So basically the formula is you put the sodium in 1 liter of whatever fluid you're administering, that sodium value, minus serum sodium, and denominator's total body water plus 1. 1 is the 1 liter you've added. So I calculated for 3% NaCl, if I'd given 1 liter, which of course I didn't, my change in sodium would have been 513, which is the sodium in 1 liter of 3% NaCl. Patient sodium 123. Total body water was 40 kg, 0.6 into 40 plus 1. So it comes to 15.6. But I've not given 1 liter, I've given 200 ml. So I expect a change of 3.12. Now, one thing which I did different was I also gave normal saline 1 liter, presuming a certain amount of body fluid deficit which was there. So that normal saline 154 minus 123, and again 25, same formula. 1.24 if I've given 1 liter, but I gave 500 ml. So I would add only 0.62 milliequivalents, not even 1 milliequivalent. So that NS plus 3% NaCl should have only increased it by 3.74. So how did it jump to 10 milliequivalents? Because he was altered, there was no other fluids going. So the only third factor which was there was the urine output. He passed at the end of that 1 hour 650 ml of urine. Now, ideally, we should have measured the sodium osmolality at least of this urine, but we didn't at this point. As I told you, it got discarded. They only measure the volume. And but by deduction, his serum sodium has gone up much more than expected. So this urine output does not have much sodium loss in it. It is free water which is coming out. So this child has excreted free water. I'm just presuming for ease of calculation, 650 ml, all free water, all may not have been, maybe 600, 550 was. So the approximate increase in sodium, if I suddenly excrete 650 ml of free water, taking into consideration his body weight, his initial serum sodium, that 123 would have gone up to 127 just by this free 650 ml free water excretion. So it would have got a 4 milliequivalent increase. So the increase has been 3.74 by what I gave, 4 by the free water excretion which happened, which was not under my control. So total would have been 7.74. But the actual increase was 10 milliequivalents. So even allowing that our calculations are imperfect, it seemed too much of a gap. There's almost a 3 milliequivalents gap over there. So there is one more mistake over here which has happened, is what I felt. So now that comes to the body weight. I've calculated on the basis of 40 kg body weight. This child, many post-transplant children put on a lot of weight post-transplant in the first year because of increased in appetite, because of uremia gone, then steroid effect, and then parents were feeling so happy that they are eating, that they give them everything. So he had gained a lot of weight post-transplant, whereas the ideal body weight for him at 10 years, sorry, that's 131 centimeters high, would have been 24 to 33 kg. So now I recalculated that if this child, because your body water is not distributed in fat, so that extra fat which he's put on, which I counted as his total body water from that body weight, I've overestimated total body water. So now if I recalculate total body water for 30 kg, then my total body water is not 24 liters, it's 18 liters. So with 1 liter of 3% NaCl, I would increase by 20, and by 200 ml, I would increase by 4. And for NS, 0.8, so I would increase by 4.8. And this 650 ml of free water excretion would, by the same different denominator, increase by 4.6. So the total increase will be 4.8 and 4.6, which is about 9.4, which is close to what we have found. So they were, the first was not an error because that is standard treatment, though I will again discuss that at the end, that maybe we can treat it more safely. Giving that sodium NaCl from the point of view of preserving hydration was not wrong, but it brings out one pointer that we cannot pigeonhole all the hyponatremias into just one slot. You know, like that is with low volume, with SIADH, with hypervolemia, etc. Sometimes you get things which are combined. So I just go to that, up to this. Okay, I'll tell you the further course before I come to that. So what we did was we reduced the IV fluids and we started oral intake for him. And we did a fractional excretion of sodium now in the next urine sample, which was 1.7%. It tells me one thing. It's very difficult to interpret after you've treated. So I can only interpret one thing from this, that in the face of 133 serum sodium, which still qualifies as hyponatremia, this sodium should have been fully reabsorbed if it was any pre-renal issue. And if it's SIADH, a fractional excretion of sodium would remain high till the SIADH got fully corrected. So it went again little favor of SIADH only. Other peculiar things we found was the fundus when we examined had retinal hemorrhages bilateral. The MRI was normal. And all the tests for malaria, dengue, EB viral load, CMV viral load, blood cultures were negative, chest X-ray normal. He remained well clinically after that. This is his fundal, multiple scattered fundal hemorrhages by the ophthalmologist shown in both eyes, but did not affect vision. On day 2, a repeat VBG showed a slight drop in sodium and he had little headache. So I think we were a little scared. So we gave 3% NaCl over 5 hours and the VBG increased to 138 sodium. Now, we're not sure why it dropped to 132. So we tried to see a tonicity balance since we have now kind of lost that acute phase where we could correct things more easily, or what you call deduce things more easily. So we tried to do a 24 hours intake output balance of water and sodium. Now the total intake was 3920 and total output 3800, so fairly closely matched. He was also taking orals now. Urinary sodium excreted was 344 sodium plus potassium. 344 in 24 hours. However, we couldn't do the sodium intake as well because we could only calculate what we gave IV. We couldn't get a correct idea of the oral sodium intake. So we don't know. So we couldn't balance. But anyway, he was excreting, seemed to be excreting the fluid part quite okay. So we calculated electrolyte-free water clearance to see, is he now able to excrete free water? Is it safe to, keep him on orals now? Or should we need to continue normal saline only? So use the electrolyte-free water clearance formula. So urine sodium plus potassium in the per milliequivalent per liter came to 90. Plasma sodium, we took a average of the 24-hour sodium, which was 135. And so you had this total volume into 0.34. So 1292 was the free water clearance. So he was clearing free water. So we know at least a liter of free water he can comfortably clear. A simple eyeballing is if your urine sodium plus potassium is less than plasma sodium, then you are excreting free water. You need to go through this if you want to know how much free water is being excreted. Okay. This is just his thing. So repeat ophthalm still showed bilateral retinal hemorrhage, but formal examination of vision was normal. Sodium was maintained at 136, 138 now without any additional efforts. So finally, we just concluded without any evidence that this is some viral infection with retinal hemorrhages, severe symptomatic hyponatremia with seizures and altered sensorium. Etiopathogenesis is a little complex because primary we feel was an SIADH secondary to the viral infection. This was coupled with almost 1 liter water intake at night when he already must have had the SIADH, which led to seizures the next morning. Probably this started earlier when he was complaining of headache in the evening. He already must have started with cerebral edema. So I don't think the serum sodium fell only at night. It had already started falling. And he used to take 2.53 liters of water for his post-transplant state. So sodium may have already been falling maybe from afternoon or something. Why am I considering that the acquired hypovolemia was an additional problem? Because he has a good urine output. He normally passes 2.2 to 3 liters per day. And the mother says still before the seizures, his urine output was normal. So he's passed a good amount of urine. He didn't get fluids for 5 hours. The moment we gave him NS and replenished his fluid, probably some physiological stimulus for ADH stimulation went away. So there were 2 stimuli for ADH. One was the viral infection with an SIADH and a superadded acquired hypovolemia because no fluids were given for 5 hours, which when we corrected, part of the ADH got suppressed and he passed a lot of free water. So could we have treated differently? One is, I think there's no option for giving the 3% NaCl, but recent recommendations suggest that give 2 ml per kg of 3% NaCl over 10 minutes or 20 minutes, depending on what you're facing and how serious the CNS issue is. Assess clinically. If no improvement, repeat another 2 ml per kg, again over 10 to 20 minutes. After 2 such boluses, check serum sodium. If it's increased by 4 to 6 milliequivalents, then you have increased serum sodium adequately to reverse cerebral edema. So if your sensorium is still bad, there's something beyond sodium that is happening. So it's your end point for this. The end point for your bolus, which you may give from 2 to 6 ml per kg, is either you get a clinical improvement, so there's no need for further rapid correction. Your serum sodium has increased by 4 to 6 milliequivalents already, so it should have reversed cerebral edema, so you need to look for other issues. Or your serum sodium is more than 120 if initial serum sodium was less than 120, whichever occurs first. Now, lastly, I'll end with dangers of treating with normal saline alone in a patient with SIADH. One, I showed you in the calculation, it's not going to increase your sodium acutely. So your 1 liter is going to increase it by 1.2 or 1.6 milliequivalent based on your basal body weight, etc. But there is dangers of treating with normal saline, that if your urine osmolality is greater than 500, then you have a risk of desalination by the kidney and worsening of hyponatremia. So in a child like this who has 123 sodium and is altered sensorium, he's definitely got severe cerebral edema. So even a drop of sodium of 1 or 2 milliequivalent can push him to respiratory arrest, coning, etc. So we don't even want a 1 milliequivalent change. And this is what we mean by desalination. Like supposing I give 1 liter of normal saline. Okay. So I have 150 milliequivalent sodium, 150 milliequivalent chloride, that is 300 milliosmoles in 1 liter. So normally if my kidney was functioning intact and there is no, the ADH mechanism was also intact, then if I don't need this saline which I've given, my kidney will excrete it in the same way, in the same composition. But I have now an ADH which is secreted, which is due to a different stimulus and which is not going to go away. And I have an ADH which is which is giving me urine concentration more than 500 milliosmoles, say 600 milliosmoles. So now what happens is my kidney can now excrete this 300 milliosmoles in just 500 ml of water, because it is already raised to 600 milliosmoles. So it doesn't need 1 liter of water. It needs only 500 milliliter of water. So it will excrete that sodium, but it will retain the remaining 500 ml as plain water and it will go back into the system. Okay. So it is desalinating this water. It is taking out the saline and giving you free water. So this 500 ml goes back into the bloodstream and will actually lower your serum sodium. It's like giving 5% glucose 500 ml. So there is dangers in treating hyponatremia with pure saline. The only exception is when you have hyponatremia due to gastroenteritis, which is due to dehydration. You can treat with saline if they are not very symptomatic. So I'll sum with that whether it is salt, it's sugar or water, poison is in everything. No thing is without poison, and it's the dose that makes the poison.
Thank you very much, ma'am. It was very interesting and very fascinating.
Yeah. So I think this child, actually, we don't have a very firm diagnosis of what caused the hyponatremia. It is more by association of the symptoms we had and how it evolved and how he behaved after just that 500 ml NS, which was just 10 ml per kg for him, a little more than that, with such profound diuresis. Almost like 15 ml per kg of urine he passed in that 1 hour. So a very good urine output is actually a dangerous sign when you're treating either hypernatremia or hyponatremia. So if your resident says the output is good, go and see the child, because the child might deteriorate because he may have excreted much more water than you planned it, or reverse happens in hypernatremia. You're excreting much more sodium than what you wanted to fall.
And so, as we see, so in the second case, so there is in our hand to kind of adjust for that urine sodium, which might be like, we calculated correctly, but we were not able to measure. So retrospectively, we can always go. But many times clinically also we feel the same scenario that in spite of we have calculated the ideal sodium thing, fluid and everything, but we are not getting the result. So maybe there is no way to like measure to decide about the urinary sodium, especially when we are correcting, depending on the etiology of the condition. Like
See, you can measure, like I said, there were many kind of things which we didn't do, lacunae in the care.
yes.
We didn't get that, collect that first sample. That was intentional. We didn't want to catheterize. Though I think a simple in and out catheterization would not have harmed him. You know, we could have just collected the sample, but we didn't do that. So that first sample always tells you a lot of things before you have intervened. Once you've intervened, then to interpret your urine electrolytes will have to be into the context of what is the electrolyte and clinical status at that point and that electrolytes, because the urinary electrolytes are dynamic. It will match your whatever's happening in your body at that point of time. Account. So it may become difficult to interpret like what textbooks tell you if you don't have the first sample. So that is the thing. And many times it will never be as accurate as we are thinking it will be by calculations, because we have to understand all calculations are defective. Sodium is not only in the blood compartment, it is in the interstitial compartment. There are different ways they equilibrate sodium and chloride across the interstitial space, intracellular movement, etc. All these rates are a little different. They are not uniform, everything. Now we are ignoring many of these aspects, and we are taking a simplified equation to give you. But even when you use the Adrog-Madia's formula, it is not taking into account your urine output. Because the body is reacting moment to moment with ADH, and if your kidney is intact, kidney will respond to that ADH. So that dynamic care which the body is giving, you have to take into consideration what will happen, but it is not predictable. So that is why it will not go according to your calculation, because you're not factoring in all these factors. So it's a rough calculation, but it should be somewhere close to it. What happened in this case was it overshot. If it had got risen instead of 3 by 5, probably I would not have spent so much time calculating. But because it went from my expectation of 3 or 4 to 10, and I could not explain it. And so I went into all these calculations. And even after that, I found I have a discrepancy. And then it struck me that I've calculated on 40 kg body weight, which is more than 10 kg will be fat. So let me check what his ideal body weight would be and calculate the total body water from that. So that's an important lesson, that when we do these calculations, have we taken ideal body weight? We usually take the actual body weight. And this is especially true nowadays because children are obese. So when you see an overweight or slightly obese, they may not look fat, but when you see the weight and the BMI, this one's BMI was way ahead of the 95th percentile, this boy's. So obviously that fat I cannot take for calculating total body water, like 0.6 into weight. If all the good proportion of that weight is fat, I have to take a different thing. So you take the ideal body weight. So I think if I take an ideal body weight, it would have been better. The normal saline response was a little unexpected, that he would pass so much urine at one point of time. So the option for that is that if you are getting unexpected increase, which could be risky for the brain for osmotic demyelination, because of the chances that this may have evolved more slowly than what you think, which is a possibility, then the suggestion is to reverse it. So my target was, say, I wanted from 123 to say 126 or 127. Say okay with the 5 milliequivalent rice at the most. So, and I've got 133. Now I recalculate from 133 to bring it down to 128, how much 5% glucose I should give in 1 hour and give it. And lower the serum sodium acutely to your target level. The alternate way of doing it is giving IV DDAVP. We don't get intravenous DDAVP, is to give 6-hourly DDAVP and titrate your fluid and sodium content of the fluid delivered so that you get that fall. So these are actually now recommended for management when you overshoot in adults. You don't have a very strong recommendation for this in children, but it's also used in children. But you have to know what you're doing. You have to set a goal. You have to calculate. You have to monitor. You can't just give. If you've given that, then 1 hour later, you have to see where you've reached. And according to literature, as something which has risen very rapidly, unexpectedly, if you bring it down immediately in the next 1 hour, it will not cause osmotic demyelination because you've not given it that much time. It's gone up, and before anything can happen, you brought it down. So that is one option of management, which we did not do because I felt like Jyoti felt that this is acute. So even though it has overshot, probably it's okay, because everything happened from that previous night, evening. So it was less than 24 hours that happened. So I took it as a very acute occurrence. And so I didn't attempt to revert it or anything.
And the same question, one more question, like, when theoretically, even for acute hyponatremia, also we try to kind of decrease it gradually. But when practically, many a times, especially with all those AG and such kind of patients, it's not possible for acute hyponatremia. Somehow, by hook or crook, the sodium will rise kind of a bit in unexpected way. And I personally have not seen many effects. So, ma'am, what is your experience that, such patients who are having that acute hyponatremia, if corrected in a bit more hurried way? So, do you also often find some issues with
invariably in diarrheal dehydration, it gets corrected very rapidly.
Yes, ma'am. Yes.
One is because of that rapid correction in diarrheal dehydration. Yes. So I think it is based on the fact that most of these are acute diarrheas. The child has come with acute watery diarrhea and lasting for a day or so, become quite, the ones who come hyponatremic are the ones who come more severely dehydrated and come earlier. Because the volume vascular compartment is not maintained in the face of hyponatremia. Yes. So they also come early. So it is usually a short history. So I don't think the CNS has adapted to that low sodium and all those things have happened. So you correct it, so you prevent cerebral edema, and the rest, rapid rise is not really going to affect very badly. So I think it's mainly because they are acute that we don't see any ill effect of those rapid rises. And the rapid rise occurs because we are thinking it as sodium loss, water loss. Hyponatremia is always because of excess ADH, 99% of the time. That ADH may come physiologically because you're hypotensive or severely hypovolemic. Your normal trigger for ADH secretion is hypertonicity. Your osmolality, effective osmoles increase, you will secrete ADH so that you retain water, and the sodium is maintained in that small, 3 milliosmol range, which is normal. But the second physiological stimulus is volume contraction. But ADH is not sensitive to volume contraction. If you just have 3% dehydration, 5% dehydration, you won't have much ADH. Your renin-angiotensin will take care of the volume. ADH comes into play when your dehydration becomes more severe. So when you have like you could say like 7% dehydration, 6%, 7% dehydration. And now your volume is not maintained only by renin aldosterone, even though it's at its maximal. ADH will come into play. And that time the volume stimulus will override your osmotic stimulus, because volume is more important for the body. So you will retain free water. Renin-angiotensin gives you salt and water. ADH is going to retain only water because now it's concentrating only on volume. So you're going to dilute the sodium. So irrespective of your losses, you may get that, whatever nature of your losses were there, whatever you were taking, it's because your kidney now cannot handle that free water, cannot retain it, so, or excrete it rather, that you're getting this hyponatremia. So now what happens when you give your 20 ml per kg bolus, which we give unthinkingly, it's a spinal reflex now. It's not wrong. You give that bolus, you've already corrected 2% of your dehydration. And you give another 10 ml per kg, you corrected, up to 3% or 30 ml per kg, you've corrected. Your ADH stimulus may go away. So your urine output starts. You're happy because you've given a bolus and the urine output starts. You're looking from an AKI point of view. But that urine is a lot of free water because now the ADH is suppressed. So now the free, your hyponatremia. So kidney and ADH are doing their work. ADH gets suppressed. Kidney dilutes the urine, excretes free water. So your sodium jumps. Now, if you also calculated sodium deficit and given according to that, you're adding insult to injury. Because already your body is doing it. It's excreting the free water. You don't need to give that extra sodium. You just need to keep hydration with an average amount of sodium. So we calculate that sodium deficit and add to that, as the kidney does not exist. So that is why it gets overcorrected. It's difficult to correct that slowly.
Thank you, ma'am.
So is there anything more or should we end?
Madam, have you used tolvaptan in any of your SIDH patients in pediatrics?
No, I have not used tolvaptan in any of my cases, but I was involved in the care of somebody else's patient tolvaptan. It was a little bit of a chronic hyponatremia, not an acute one where it was used. So most of the recommendations for tolvaptan is more for chronic hyponatremia, which is persistent and where, just fluid restriction to that extent may not be feasible, all that kind of thing.
Yeah.
Where you don't have a volume contraction, that part is corrected.
Right. Okay, ma'am.
So
you wind up. Yes, ma'am. Thank you very much, ma'am. It's been a great session.
Yeah, thanks, Jyoti. Yeah. Bye.
Bye, ma'am.